ready? Good morning, everybody. My name is Allison Sonnenschein, and I'm the founding director of the Orange County Women's Health Project. Thank you so much for joining us today for the 8th Orange County Women's Health Summit. Today is the 4th and final session in this 4-part series. Next slide, please. So as you can see on the slide, we have covered a lot of ground. The first session, which was on Friday, May 29th, covered a high-level overview of how COVID-19 is affecting women's health. And we also had a very rich discussion about adverse childhood experiences, also known as ACEs, and the interplay with COVID-19. The second session on Wednesday, June 3rd, explored how COVID-19 is affecting sexual health education and service delivery in Orange County. Last week on Wednesday, June 10th, during the third session, we explored what are the policy implications for women's health surrounding COVID-19. What types of changes have already happened and what would we like to see moving forward? And finally, today, we are going to address how COVID-19 is affecting mental health. Next slide, please. So we have a terrific panel today, and I'm just going to give a very quick preview. Dr. Clayton Chama will be explaining Be Well Orange County and how COVID-19 is affecting mental health in general. Then we will hear from Dr. Diana Ramos, who will be speaking about perinatal mental health and COVID-19. And finally, Dr. Michelle Park, who will talk about the impact of COVID-19 on caregivers as well as seniors. Moderated entirely by Gail Dratch, the mental health specialist for the Orange County Women's Health Project. Next slide. So very quickly, many of you have been on these sessions before, so I just want to very briefly review the logistics. We are recording this session, and all 4 of the sessions will be available for viewing on our Summit website. You will see in the chat box a link to the Summit website, the particular page where you can find the recording from all 4 sessions, as well as the PowerPoint slides. We are also asking that if you have any questions, you submit those through the Q&A feature. And if you need tech support, please use the chat feature. Next slide. We also greatly appreciate your feedback and ask that you complete the evaluation survey. You will be automatically directed to at the end of the session today. And if you are interested in receiving continuing education, CEUs are available for chess, nursing, LMFT, LCSW, LPCC, and LEP. You will have to complete a CEU request form in order to receive your CEUs. Finally, we'd like to highlight that we have 6 virtual poster presentations that cover various topics affecting women's health in Orange County, and you can watch those presentations on our Summit website. Once again, in the chat feature, you will see a link to the page on the Summit website where you can find these 6 virtual posters. So thank you to our presenters for adapting your presentation for this online format. Next slide. I'd like to thank once again, and with deep sincerity, our very generous sponsors who have made this Summit series available, especially at no charge this year. I will begin with our lead sponsor at the ambassador level, the Arduous Family Foundation. The champion level, we have Carrie and Danny Sonnenschein, Sheila and Igal Sonnenschein, and the California Wellness Foundation. Guardian level, the Shaw family and Planned Parenthood of Orange and San Bernardino counties. At the advocate level, Pamela Gilmore and Hoag Women's Health Institute. And finally, at the activist level, we have Suzanne and Richard Wagner, the Francesca and Giovanna Family Fund, CalOptima, Orange County United Way, and 501c Insight. Thank you for all of your generous donations and sponsorships. Next slide. I'd also like to thank and acknowledge our extraordinary advisory board, and you can see their names listed on this very dense slide. Many of these champions for women's health, have been with our organization from the very beginning, and we could not do what we do without your vision and expertise. I'd also like to thank and acknowledge the team here at the Orange County Women's Health Project. Throughout the summit, you have already seen and met my colleagues Dina Rubin and Mona Shah. Today, you're going to meet Gail Dratch, and behind the scenes, working diligently to ensure a smooth planning and delivery of this virtual summit series has been Sydney Minchin. So I want to thank you all for your exceptional work on the summit series. Next slide. So to begin, we're going to have two questions that we will ask for you to complete using the poll feature. So Sydney, I will ask you to please activate the poll. We'd like to know two things from you. First of all, who's in the audience today? We are really excited. Over 260 people have registered for the session this morning. And we do have a sense from your registrations what type of work you do, but we'd like to see who's actually with us this morning. And if you work outside of the home, there are 9 options. And if you are retired, if you no longer work, then please choose the first option, community member or volunteer. The second question is a true or false. So take your best guess. The CARES Act provides funding for mental health related to COVID-19. So we'll keep these two questions up for about 5 more seconds. And then I will ask Sydney to close the poll and share the results. Great. So as you can see, about 50% of you on the line today are educators, faculty members, or health educators. We also have a fair number of nonprofit and community-based organization staff, social workers, therapists, and counselors, students, nurses, community members and volunteers, and a handful of health system, hospital, and clinic staff. So that's terrific. And we are dead even split on the true or false question. So let's talk about this. Sydney, please close the poll and we'll proceed to the next slide. Okay, so the answer to this question is very fortunately true. The Coronavirus Aid, Relief, and Economic Security Act, also known as the CARES Act, has provided substantial funding to support mental health services, outreach, technology, all different types of applications specifically related to COVID-19. So 2 important elements of this funding: $426 million has been allocated to SAMHSA, the Substance Abuse and Mental Health Services Administration, for COVID-19 related mental health. That includes funding for CCBHC clinics, COVID-19 emergency response, suicide prevention programs, and for tribal communities. In addition, nearly $20 billion was allocated under the CARES Act for the Department of Veteran Affairs. And as you may recall, if you joined us last week, the CARES Act is the single largest federal relief fund in the history of this country. And so there is additional funding that has come from several other pieces of federal legislation. We also have pending another federal bill called the HEROES Act. It was passed by the House, and it's kind of a wish list for additional funding, which includes additional funding for mental health services. But it is worth noting that the CARES Act is the law today and did include almost $20 billion to the Department of Veteran Affairs, which included funding specifically to expand mental health services delivery through telehealth, especially for our homeless veterans. So that's good news to see that we have meaningful resources to support this very important issue. Next slide, please. So as I have done in the first 3 sessions, we are going to very quickly run through what is the state of COVID-19 today in Orange County. This first slide summarizes where you can find information and resources on the healthcare agency's website for Orange County. I'm not going to go through it individually, but all of these slides, as I mentioned earlier, will be available on our website later today or by tomorrow morning at the latest. And these links are all hyperlinked, so you can access this information on your own. Next slide, please. This is a new slide. I just wanted to illustrate that over the 3.5 weeks that we have been conducting this summit series, you can see the increase in the number of cases in Orange County and the increase in the number of deaths due to COVID-19 in Orange County that have been documented to date. So starting on Friday, May 29th through yesterday, you can see that we have gone from 5,744 to 8,999 cases in Orange County, a total increase of a little over 2,200 cases, which is roughly 39% increase in just 3.5 weeks. But even more compelling, I think, is the percentage increase. And you can see that week after week, we are picking up the pace of the increased number of cases. So we've gone from 14.5% to almost 16% to a little over 18% in the increase week after week of COVID cases in the county. Similarly, you can see the same trend in the death counts in the county. We've gone from 145 3.5 weeks ago to 233 yesterday, which represents an increase in 53 deaths in the county. But you can see a week after week increase in the rate of the increase. So that's just a short period of time, but I wanted to highlight how COVID has evolved in just the 3.5 weeks that we've been presenting this summit series. Next slide, please. So this slide highlights what the gender breakdown is, and you can see that it's almost even the number of cases split between men and women in the county. And as you may be aware, our county of 3.1 million plus residents is slightly more than 50% female, slightly less than 50% male. So the COVID case count is tracking pretty closely to the overall population broken down by gender. However, that's not the case with the death counts, where we see higher mortality among men in Orange County than women. And as of yesterday, it was 56% of the deaths due to COVID-19 were among men, 44% among women. And this is pretty comparable to what's happening across the country. We're seeing men suffering higher mortality rates than women across the country, in particular, Black men. They're experiencing the highest death rates of all population groups broken down by racial and ethnicity. Thank you. Next slide. Now that we're talking about race and ethnicity, this slide just illustrates what is the breakdown by race and ethnicity of the current cumulative cases in Orange County. And I just want to acknowledge that for 27% of COVID-19 cases in Orange County, we still do not know the race or ethnicity of the individual. So these data are considered pretty unreliable, but it's the best we have. Nevertheless, we really can't draw any conclusions about racial or ethnic disparities in the case count. Next slide. However, we can see in the death count, which this slide illustrates, that we do know the race and ethnicity of all but 1% of the COVID-related deaths in Orange County. And as you can see, there's a pretty wide distribution. Most of the races and ethnicities that are reported here on this chart track closely to the racial and ethnic breakdown of the overall population of the county. So for example, we're seeing in the dark blue, 37% of all COVID-related deaths are among white individuals in the county. I think we're about 36% of the overall population in Orange County is white. And so you can see that's pretty similar. The only notable disparity is among the Asian population in Orange County, where here we see 18% of the COVID-related deaths are among Asians. And I believe that the API population in Orange County is closer to 8%. So that's a pretty notable difference. But once again, these data do not capture all the variables that can influence mortality among different races and ethnicities. and the numbers are changing every day. So it's a little early still to draw any firm conclusions about racial or ethnic disparities in the death count. Next slide. This slide highlights the age distribution, and I really just want to acknowledge that what we're seeing in Orange County is very similar to what we're seeing around the rest of the country, which is to say, forgive me for a moment, that while 77% of all COVID cases are affecting adults between the ages of 18 and 64, the same population represents only 25% of all of the deaths from COVID-19 in Orange County. And in contrast, we see that 18% of all cases are among seniors ages 65 and older, but that same population, seniors, represents 75% of all of the deaths in Orange County. So this is a pretty significant disparity that we're seeing reflected across the country. We are now seeing a handful of cases, 5% among children ages 0 to 17. Fortunately, no deaths among children. Thank you. Next slide. And finally, I just wanted to acknowledge that the Orange County Register is tracking on a daily basis the COVID counts by city. They're drawing some of the data from tables available on the Orange County Healthcare Agency's website, but they're also calculating rates. So you can compare on the left the map, which shows the darkest red indicate those cities that have the highest case rates. That would be cases per 10,000 residents in a city. And on the right, you can see on the first column, those cities that have the highest number of cases overall. So we're kind of in the weeds in this particular slide. I'm going to leave it at that, but you can link to both the map on the left and the table data on the right when you access the slides in the future. Thank you. Next slide. Well, with that high-level overview of the state of COVID-19 in the county, it is now time to move on to the panel, and I am really pleased to be able to introduce our moderator today, Gail Dratch, who is the mental health specialist for the Orange County Women's Health Project. I imagine many of you know Gail because she has spent most of her career working with the county, specifically in the healthcare agency. The bulk of her time was spent in the maternal child adolescent health division, where she directed case management programs for pregnant and parenting teens. But she also spent the latter part of her career working with Mental Health Services Act, or MHSA funded prevention and early intervention programs by which the county would contract with community agencies that she helped to select, oversee, and support as they delivered programs and services designed to reduce the incidence and the severity of mental illness in Orange County. For the last few years, Gail has been teaching undergraduate social work classes at Chapman University, and she herself earned her master's in social work at USC. So thank you so much for joining us today, Gail. I'm going to hand it over to you to introduce and then moderate the panel.
Thank you, Allison. I appreciate the opportunity to moderate this panel of experts on the topic of COVID-19 and mental health. During this next panel, you will have an opportunity to hear from 3 experts in the field about how the pandemic is impacting the mental health of Orange County residents, primarily women and seniors, and how the county is responding. And now it is my pleasure to introduce our 3 next speakers. After their presentations, we will have an opportunity for a question and answer period. These speakers have long, impressive bios, so I'm just going to hit some of the highlights. For more comprehensive introductions, please go to our website. Our first speaker, Clayton Chama, is the director of the Orange County Healthcare Agency and the acting chief health officer. Formerly, he was the Chief Clinical and Strategy Officer for Mind OC, the nonprofit entity which he co-founded to support Be Well OC, a private, public, faith-based academic coalition which aims to transform the mental health system in Orange County. Appointed by the 23rd U.S. Secretary of Health and Human Services, he is a member of the Interdepartmental Serious Mental Health Coordinating Committee. He is also a lecturer for the UCLA School of Public Health, an associate clinical professor for psychiatry, and the director for the transcultural psychiatry curriculum at the UC Irvine School of Medicine. Dr. Chao obtained his MD degree from the University of Minnesota and his PhD in clinical psychology from Chelsea University. He completed his psychiatry residency at UCLA San Fernando Valley, followed by a fellowship with the National Institute of Mental Health in psychoneuroimmunology, focusing on substance abuse and HIV. And yes, I practiced saying that. Dr. Chao has conducted international trainings in the areas of healthcare integration, healthcare system reform, cultural competency, veterans health, trauma, homelessness, and mental health policy. He has received numerous awards and recognition for his work. Our second speaker is Dr. Diana Ramos, and she is the president of the Orange County Medical Association and the incoming chair for the California American College of Obstetrics and Gynecology. Dr. Ramos is a well-recognized public health expert, a board-certified obstetrician gynecologist, and an adjunct assistant clinical professor at the Keck University of Southern California School of Medicine. She serves as the vice chair of the California American College of Obstetrics and Gynecology Executive Committee and other women's health committees, providing leadership and guidance to obstetricians and gynecologists throughout California and the US. Her areas of expertise include health disparities, preconception, interconception health, contraception, and quality improvement. Nationally, she is on the American Medical Association Healthcare Disparities Advisory Board, co-chair for the March of Dimes Health Equity Advisory Group, and on the board of the National Hispanic Medical Association. She has written and contributed numerous articles to the obstetrics and gynecology and public health literature, and has received numerous awards for her work. Dr. Ramos received her medical degree from the University of Southern California with honors and completed her residency training in obstetrics and gynecology at the Los Angeles County University of Southern California Medical Center. She obtained her master's degree in public health with an emphasis in management from the University of California, Los Angeles, and received her BA in communications, arts, and sciences from the University of Southern California. Our third speaker is Dr. Michelle Park, psychiatrist with Reconnect Early Intervention Services for Older Adults at the Council on Aging of Southern California. Dr. Park is a graduate of Stanford University and the Loma Linda University School of Medicine. She completed her combined residency in family medicine and psychiatry at the University of California at Davis Medical Center. She is board certified in both family medicine and psychiatry. Her professional interests include integration of mental health into primary care and mental health in emerging adulthood. In addition to her private practice, Dr. Park currently works as a per diem family medicine physician at Kaiser Permanente in Orange County and as a consultant psychiatrist on the Council of Aging. I will now turn this over to our first speaker, Dr. Chao. Should I say? Dr. Chao, you are muted. Okay.
Oh, okay. Can you hear me now?
Yes, thank you.
Okay. Thank you. Thank you. I was saying thanks to Gail and Allison for the opportunity to join this panel this morning, and welcome everyone. I hope this session will be stimulating for you. My name is Clayton Chama. I'm the current agency director for the Orange County Healthcare Agency. This is my week number 6 on the job, and I'm also the acting interim health officer for Orange County week 1. So welcome everybody. Next slide, please. I thought what I would do is to talk about Be Well Orange County, which is a movement that we started here in Orange County in April of 2017. At that time, we gathered a group of leaders in public-private health system, academia, as well as faith-based, and asked a simple question: do you believe that we have a system of mental health in this county? And obviously, the question is no. We all know that the mental health system in this county, not so different from the state or across the nation, has been silos. And majority of that is due to the different way that the government fund our mental health system. And we base our belief on what mental health should be on the WHO document, the state of well-being, which said mental health is a state of well-being in which every individual realizes or her own potential, can cope with normal stresses of life, can work productively and fruitfully, and is able to make a contribution to his or her community. And so this coalition of the willing in 2017 has a vision that this coalition will lead the nation in optimal mental health and wellness for all residents. This coalition of the willing had its official name in later on in around October or November of 2017, and the name is Be Well Orange County. You might have heard about Be Well Orange County. Since then, there's been a lot of activity around mental health in Orange County. Our goal is really to transform the mental health system, to create a new mental health system that is made available for all residents of Orange County, regardless of their insurance status, whether or not they are privately insured, publicly insured, or no insurance. Next slide, please. So this is our envisioned ecosystem for tomorrow. All these pieces together, from clinical services to criminal justice to school, etc. I mean, that's what we envision the mental health system would look like for Orange County. Next slide, please. And how do you do this with all of this different entity coming together that historically either was blaming each other for how the system didn't work or not working very well with each other due to the competitiveness of the funding availability from state as well as a federal perspective. And we model ourselves after the collective impact with a distributed leadership structure for all the entities that participate in this coalition. The last count I got, it was well over 200 organizations, large or small, public and private, academia, as well as faith-based in Orange County, as well as advocacy group in Orange County that came together to do the work, right? So it's central around a backbone, which is MINOC, the 501c3 nonprofit organization that I co-founded. The whole goal of this backbone organization is to actually facilitate, coordinate, and align funding as well as policy in programming to help us transform to a new system. The backbone, this backbone organization is not a service provider. Around this backbone are 6 different results, and each result has at least 2 entities in Orange County who are leading and coordinating the work around that result with surrounding impact organization. So pretty much this is the collective impact model that has been developed for the last decade or so and well studied and implemented across the world, stemmed out from Stanford University. So if you are interested, you can Google a collective impact and Stanford University, and there's a lot of literature on this model. Next slide, please. The 6th result that we have identified for Orange County to tackle are reduce stigma, prevent and act early, close treatment gaps, and improve access. Next slide. Strengthen crisis response, establish community wellness hubs, align partners, policy, and programs. And as you can see, each of the result area has a set of indicators that the community has come together to identify what are the goal and vision, what are the goals for each of the result area, and what are some of the low-hanging fruit that we could tackle first. To date, it sounds very nice, and in theory is really good, but you have to have something tangible for the community to see. So the first thing that we did was establish community wellness hubs, and there is plan to create 3 campuses of wellness hub throughout Orange County, North, Central, Coastal, and South. And you probably have heard about our very first campus, which is under construction in the city of Orange. That campus, the completion date for that campus is December of this year, with the start date for services in January of 2021. And that campus will house a spectrum of mental health crisis services, ranging from crisis stabilization unit, less than 24-hour services for both mental health and substance use disorder, to short-term residential crisis program up to 90 days for individual with either a mental health condition, an addictions, or a co-occurring disorder. What's interesting about this campus is it is the first of its kind in the country, we believe, where the county put in roughly a third of the funding. The CalOptima, the health plan for Medi-Cal, Medicaid individual in Orange County, put in roughly a third of the funding. And then the various health systems, such as Kaiser, Providence, Hope Hospital, Memorial Care, put in the other third to build up this new infrastructure. And the money is not a loan, but it's actually a donation to build this. And the goal is when we open for services in January of 2021, anyone live in the north and central region of Orange County would have access to services in this campus, regardless of what insurance they have or no insurance. So we are now working on the replicating some of the services, but build on it for a campus in South County. Hopefully by the end of summer, we can announce where that location is. So it's very, very exciting for us. Next slide, please. So that's a rough overview of what Be Well Orange County is. There are other activity around Be Well Orange County, such as we created a community suicide prevention initiative. We also have a community substance use disorder initiative. We are working on a platform where we centralize all of the emergency mental health emergency call in Orange County into one single number navigation system. You might not be aware of this, but currently in Orange County, if you have mental health crisis, there are at least 18 numbers that you could call. So for a family who's in crisis, the obvious number that they would call would be 911, which will eventually take them either to jail or to inappropriately to our regular acute hospital emergency room, where folks with mental illness could sit there for days on and sometimes weeks. If you talk about individual, especially women who are pregnant and have mental illness and needed a hospitalization, you could pretty much sit in some emergency room for weeks, and I have encountered those cases. So our goal is to make sure that we build a system where people can access mental health in a timely manner at the right place with the right services. So let's talk about COVID-19 and mental health. I mean, since the beginning of this pandemic, all we hear about is the physical health condition related to COVID, right? You hear about the positivity rate, you hear about the number of people who die from COVID-19, and you kind of probably have heard that the nationwide, including California and locally, the number of calls that each of our suicide lifeline and our warm line in Orange County particularly have increased tremendously. but we don't really yet know what the effect of mental health from COVID on mental health, because there's a disease uncertainty, right? There are high risk groups, and then there's also death. How does that affect the community? How does that affect the family that have had loved one die from COVID-19? Clearly, we know there's a lot of literature now talk about the mental health and the emotional wellness of the frontline healthcare providers and first responders. And particularly, there are several studies looking at the mental health needs of the frontline healthcare provider in Wuhan, China. And so if you're interested, you should Google that. It's fascinating. We also talk about social isolation, and we always use the term social isolation, but I think particularly for children, physical isolation is going to be very difficult. As we bring them back into school, how do you tell a youngster that, yes, you can see your friend, but you can't touch your friend, and you need to be 6 feet apart from them? That is going to be very, very tough, especially children with special need. I don't have to tell you the job loss and income insecurity has caused anguish for our community, right? So people who are poor are getting poorer. People who try to build a legacy for their children now have lost that dream. And then the other number that we seen a dip, and those are the number of domestic violence and the number of child abuse. But I believe that because they happen in silence, usually before the shelter at home, a woman would find a way to escape from a domestic violence situation. But with the shelter at home, where do they go? Usually it's the teacher who identifies child abuse cases, but because students are not in school and have not been in school for the last 3 months, how do they identify children who are living in abusive environment? So I think as the children are getting back out into school now, we will see a lot more of those cases. Next slide, please. So the Henry Kaiser Family Foundation have done a study looking at the percentage of adults who say worry or stress related to COVID has had an negative impact on the mental health, right? So for those who live in area where there was sheltering in place, clearly 47% of them in the survey voiced that there are a negative impact on their mental health status. And then for people who are not in shelter in place, there are 37%. So clearly there's a statistically significant differences between those two different populations. Next slide, please. So because this is a women's wellness conference, what about COVID-19 and women's mental health? International data have shown that women have been more likely to experience symptoms of stress, anxiety, and depression during the pandemic. There's an Australian study showing that loneliness has been more of a problem for women than men in this past month under the lockdown. Caregiver load, which I believe Dr. Park is going to talk about, has also been a source of stress, with women almost 3 times more likely than men to be looking after children full-time on their own during COVID-19. And certainly at the healthcare agency, we have had women staff who telework now really are affected by their work full-time, providing the mental health services for the community, and yet they also have to take care of their children who are studying from home. And how do they juggle that, right? We do know that younger female workers are disproportionately affected by the kind of economic crisis in the wake of COVID-19, because historically we know there's a pay differential unfairly between male and female workers in this country, or globally for that matter. And then globally, other places have reported an increase in number of domestic violence. And I believe that as we are releasing, lack of a better word, people back into the community, these numbers will rise with all the stresses that have been happening for the last 3 months onto a family. So next slide, please. So how does COVID-19 affect the mental health system? Express Script has recently reported that in the last 3 months, they've seen a 40% increase in the prescription of anxiety pills, 20% increase in prescription for depression medications, and a 50% increase in sleeping pills. There's an uptick calls to our hotline room, as I mentioned to you. And WebMD has polled among all the readers, 3,100, and found that 26% said that they felt a sense of trauma from COVID-19. And I think the trauma will continue, especially the thing that keep me up at night is when we bring the children back into school, this physical distancing will be another source of trauma for our kids. Next slide, please. So the long-term effects of the pandemic, there's several studies looking at this, particularly on our experience of the Asian economic recession between 1997 to 1998. As the unemployment rate increases, there's an increase in suicide, particularly in Japan, Hong Kong, and South Korea. And that effects actually have been seen in these populations here in the US, especially in Southern California. If you remember, there were several cases, Korean and Chinese men who burned themselves and their family, or family suicide happening during those 2 years because of the unemployment and the economic burden and the economic hardship. The longer that there's unemployment, the longer there will be mental distress and increased risk of suicide, and we know that. So how do you balance the shelter in place and the downfall of our economy, the unemployment? That is a really delicate situation that everyone have to deal with, right? Not just politicians, but also as a healthcare provider. There's a study that's shown and published in World Psychiatry looking at suicide, that it is highly linked to unemployment in financial insecurity situation, and that the predicted model is that for every 1% increase in unemployment, there will be a 1% increase in suicide. That would translate to about 8,000 to 10,000 additional suicide in the United States as a consequence of the pandemic. And so if you is not aware of this, every day there's roughly, before the pandemic, every day there's roughly 135 deaths from suicide occur here in the United States. And that is a very conservative estimate, which come about to 49,000 deaths related to suicide in this country. And again, that is a very conservative number. Next slide, please. So what are some of the strategy from an individual perspective? We encourage our clients to eat and sleep well, stay socially connected, even though you physically can see each other, you have shelter in place, but leverage technology to stay connected to your friend, your neighbor, and your family. And then really limit the news and the social media, because it's very, very negative, as you probably have experienced this last 2 days, as it related to some social injustice issue in this country. Specifically, I'm talking about Black Lives Matter. From a community perspective, we need to rally together to support the vulnerable, the senior, the children, the frontline healthcare workers. We need to ensure that we have this neighborhood connection, right? You've seen pop-up food drives and safety and wellness check on their neighbor, etc. These are pocket hotspot of goodness that we don't see enough amidst all this negativity in social media. And at the healthcare agency, we are attempting to bring all those positive pockets in our community to share widely. From a system perspective, we need to increase mental health care. We need to increase access to care, leveraging telehealth, leveraging technology. And clearly, physical health, mental health, and substance use treatment integration is as important as it is now. I mean, we've been talking about it for the last decade, but this is the time that we really have to do it. Next slide, please. And so here are a list of resources that I put out. I mean, I forgot to mention this, but those of you who are in the audience viewing this, you could take out your iPhone or your Android phone and take a picture of all this slide. You don't need to wait for the PowerPoint to be available later on today or tomorrow. Any slide that is important to you, you can take a picture. And so these are some of the relevant number that I believe you need for this topic today, but you certainly can get onto the Orange County OC info, healthinfo.org, and we have listed, we have lots of resources available, as well as the Be Well website, www.beweloc.org. There's a lot of resources that have been published relevant to COVID-19 as well. So I think that is my last slide. Next, please. I think we are keeping this the question and answer to the end. I want to thank you for your attention, and please be safe and be well. And I'm going to pass the next section over to Dr. Ramos.
Hi, Dr. Ramos. I'm just going to ask you to unmute real quick. I cannot hear you. It looks like it's trying to connect your audio. Oh. I still can't hear you, unfortunately. So I think we might pass the presentation to Dr. Park, and I will work with you offline to get your audio up and running. Oh, can you try speaking again? Okay, I cannot hear you. So I'm going to actually ask to pass the presentation to Michelle Park, and I will connect with you offline.
Hello. While we're waiting for my slides to come up, I just want to say thank you to the Orange County Women's Health Project for inviting me to speak today. And I'm honored to be in such impressive company with my illustrious colleagues, Dr. Chow and Dr. Ramos. All right, here we go. I'd like to begin by giving a brief introduction to my organization, Council on Aging. Next slide, please. So I've been privileged to be the consultant psychiatrist for the Reconnect program within the Council on Aging Southern California for the past 5 years. The Council on Aging is a nonprofit organization that has been here in Orange County for 47 years. And as you can see on the screen, has various programs to provide advocacy and protection, prevention and wellness, and education and outreach services to Orange County seniors and caregivers. The goal that drives our work is to keep seniors healthy, connected, seniors healthy, connected, and protected, which ties in well to my topic today, which is regarding the impact of COVID-19 on seniors and caregivers' health. Next slide, please. So I'd like to set the stage for speaking about the impacts of the COVID-19 pandemic by first talking about caregivers and care recipients in the US and what we already know about the health risks and benefits of caregiving, with a particular emphasis on mental health. Then I'll shift to speaking about what we know about the impacts of COVID-19 on these populations. And finally, I'll discuss ways in which we can support and advocate for caregivers and older adults. Next slide, please. So first, next, please. I'd like to define the term caregiver as someone who provides unpaid care or support to a friend or family member. Next, please. Older adults or seniors are defined as anyone over 60 years old. And next. I'll also be referring to some generational trends. So the definitions and approximate age cutoffs for the generations are listed here. So please take a moment to note your own generation. I did not know these cutoffs, so this was very interesting for me. So Gen Z is anyone 23 and younger. Millennials are 24 to 39 years old. Gen Xers are 40 to 55 years old. Boomers are 56 to 74 years old. And the silent or greatest generation are 74 years old and older. Next slide, please. So this graphic and many of the following are from a study called Caregiving in the US 2020, which was presented by the National Alliance for Caregiving and AARP based on data collected in 2019 from nationally representative quantitative online surveys with over 1,300 caregivers. This study was compared to the prior study conducted in 2015, and as you can imagine, provides a great deal of information about the state of caregiving in the US. So as you can see in the graphic, the absolute number of caregivers as noted on the left has increased over the past 5 years, as has the prevalence of caregivers as noted on the right. 1 out of every 5 American adults is providing care to someone in a given year. So when I speak of caregivers, I imagine that we all have a personal connection, either because we ourselves are caregivers, or we have loved ones who are caregivers, or we are care recipients ourselves. Next slide. So who are today's caregivers? Caregiving remains an activity that occurs among all generations, racial, ethnic groups, income or educational levels, family types, gender identities, and sexual orientations. That being said, next please. There is a gender disparity such that 61, as noted in this study, but I've also seen estimates of as high as 75% of all caregivers are female. Next please. The average age of caregivers is 49.2 years old, which lands in Generation X. But as you can see, the largest proportion of caregivers are boomers. Over half of all caregivers are over 50 years old, and over a third are over 65 years old. We also see a not insignificant portion of caregivers, 7%, who are over 74 years old. Older caregivers tend to take care of similar age recipients, with 74% of caregivers aged 75 and older caring for a recipient of the same age, while younger caregivers tend to take care of someone older than themselves. Next slide, please. In terms of race and ethnicity, the demographics of caregivers follow the demographic distribution of the US at large, which is to say 62% white, 13% identify as African American, 17% Hispanic, and 6% Asian American. However, the prevalence of caregiving is higher in our communities of color. Next, please. As you can see, 21% in the Hispanic community, about 20% in African American and Asian American communities, and about 17% in the white community. Of course, there are differences in the experience of caregivers in different ethnic groups. For example, Hispanic and African American caregivers experience higher burdens from caregiving and spend more time caregiving on average than their white or Asian American peers. More than half of African American caregivers find themselves sandwiched between caring for an older person and a child, or caring for more than one older person. I bring this up to highlight that structural inequalities impact caregiving just as much as every other aspect of our lives. Some other communities that are also represented in the caregiver demographics are veterans, and next slide, or next point, and folks identifying as LGBTQ. All right, next slide, please. In general, there are more sandwich generation caregivers. Next, please. Compared to 2015, more caregivers are taking care of 2 or more care recipients. And also, next, please. 3 out of 10 caregivers live with a child or grandchild. Next, please. 89% of caregivers care for a relative or loved one. 50% of caregivers are caring for a parent or parent-in-law, that's the most common, followed by 12% caring for a spouse or a partner, 10% for a friend or neighbor, 8% for a grandparent, and 6% for an adult child. Many caregivers live together with their recipient, about 40%, a proportion that has grown since 2015. Next slide, please. Now, shifting gears, I would like to describe who the care recipients are. Next, please. Yeah. 2 out of 3 care recipients are women, 61%. And next, please. Oh, I'm sorry. Could you go back? I apologize. All right. I'm referring to the graphic on the right. On average, the recipient is 68.9 years old with a median age of 72 years old. About half of caregivers of adults are caring for someone 75 or older, with 40% caring for someone age 50 to 74. So just to take a step back, when we're talking about caregiving in America, I wanted to highlight that in the majority of cases, we're talking about middle-aged to older adult women caregivers taking care of mostly older adult women care recipients. Next slide, please. So caregiving is an essential but largely an acknowledged part of our economy and society. Caregivers provide an estimated $470 billion worth of unpaid care, as estimated a few years ago, which is an amount which exceeds the value of paid caregiving and is roughly 3 times the total amount of Medicaid spending on long-term services and supports. Yet, despite providing such an essential economic service, next please. Was there another bullet? Sorry. Oh, sorry. Go back. I apologize. All right. Unfortunately, about half of caregivers have experienced at least one negative financial impact as a result of caregiving, with 34% who have experienced 2 or more financial negative impacts. For example, having to stop saving, taking on more debt, using up personal savings, leaving bills unpaid or paying them late, or having to borrow money from friends or family. About 61% of caregivers, as you can see in the graphic, continue to work part or full time while caregiving. And about 1 in 5 caregivers report experiencing high financial strain as a result of providing care. Next slide. So caregiving, just as there are financial risks and impacts to caregiving, there are also health impacts. When it comes to mental health, there are many studies that consistently report higher levels of depressive symptoms and mental health problems among caregivers than among their non-caregiving peers. By one estimate, 25 to 50% of caregivers meet criteria for major depressive disorder. Caregivers also suffer from higher levels of stress, frustration, isolation, and loneliness. The mental health risks seem to have a disproportionate impact, unfortunately, on women caregivers who have higher levels of depressive and anxiety symptoms and lower levels of subjective well-being, life satisfaction, and physical health versus their male counterparts. According to one study, there is a dramatic increase in risk of mental health consequences among women who provide 36 or more hours per week of care to a spouse. Next, please. Unfortunately, in addition to the mental health risks, which in and of themselves can also confer physical health risks, caregivers suffer from increased risk of heart disease, increased tendency to develop serious illness, and have high levels of obesity and body pain. Caregivers' self-rated health seems to have declined during the past 5 years, as you can see in the graphic on the right. More caregivers now report that their own health is fair to poor. 1 in 4 find it difficult to take care of their own health, and a similar proportion reports caregiving has made their own health worse. In another national survey on caregiver health, more than 1 in 5 women surveyed had mammograms less often. So there is concern that caregivers are feeling less healthy and also less able to engage in preventative screenings and care. Next, please. Despite these very real benefits, I definitely wanted to highlight that there are positive benefits to caregiving. In one study, 83% of caregivers viewed caregiving as a positive experience, and half of all caregivers feel their role as a caregiver gives them a sense of purpose or meaning in life, even as these emotions often coexist with feelings of stress or strain. Next slide. So now I'd like to bring us back to discuss this unprecedented time that we are all living in, that we've been impacted by a global pandemic. Before we zoom in on the impacts on older adults and caregivers, I wanted to give some context to what we know about how COVID has affected the mental health of our population at large. You saw this graphic in Dr. Chow's presentation, or part of the graphic, there was a graphic that referenced the same Kaiser Family Foundation poll. But just to review, about half of all Americans have reported a negative impact on their mental health due to the pandemic. And I just want to note that this poll was taken at the end of March, and clearly we have suffered through several more months of this pandemic dragging on, so I would not be surprised if this proportion is much higher. And about a third are now showing signs of clinical depression or anxiety. Next slide. Many professional organizations and health departments across the world have been particularly concerned about the negative mental health impacts on older adults of COVID stress and sequelae of the social distancing measures that many countries have needed to impose to slow the rate of infection. We have all been rightly educated about the increased risk that our older adult population faces in terms of age-related increases in case fatality rates. Next, please. So we are seeing for ourselves in California that older adults are disproportionately at risk. Allison mentioned our county numbers at the top, but as far as the state is concerned, per the California Department of Public Health, more than 85% of deaths in California have been in older adults over 60, with residents of nursing facilities representing approximately 42 to 45% of total deaths in California. This proportion tracks with what is happening all around the world. In Belgium, for example, 53% of the country's entire number of COVID deaths occurred in care homes, and in Spain, it was up to 67%. The stress conferred by the reality of these numbers and the trauma that our older adults may have already experienced due to losses of loved ones are concerning for what some are describing as a concurrent developing national mental health crisis. Next, please. The research has shown that older adults are already at risk of poor mental health due to experiences such as loneliness and bereavement, and loneliness has obviously been exacerbated for many during this pandemic. The Kaiser Family Foundation poll that Dr. Chow referenced showed that significantly higher shares of people who are sheltering in place and socially distancing reported negative mental health effects resulting from worry or stress related to COVID compared to those who are not needing to shelter in place. Next, please. So I also wanted to highlight the challenges that some older adults who are grandparents are facing due to the pandemic, as encapsulated by these two quotes that I found in articles recently published about this topic. So the first is from Dr. Ann Steffen, who is a professor of clinical psychology at the University of Missouri, St. Louis, who specializes in older adults and behavioral medicine, and was recently quoted in an article saying, COVID-19 is creating a new cohort of people who are identifying themselves as caregivers for the first time because it's creating a need that hadn't been there. So more than 70 million people are grandparents, and many live with multiple generations under one roof. And 42% of all grandparents living with grandchildren are actually their primary caregivers. Per Dr. Madonna Harrington Meyer, who's a sociology professor at Syracuse University and author of Grandmothers at Work, the trend of intensifying grandparenting, or grandparents taking on more active roles in child-rearing and house management, has been increasing over the past few decades, and notes that although providing childcare can provide benefits for the grandparents who are doing so, such as more physical activity, running after the kids, healthy emotional life, and more socializing, the additional stressors can also lead to burnout, as with all caregiving. So as she puts it, let's put up the next quote. All the grandparents in the country are aching. Some are aching because they can't see their grandchildren, and some are aching because they can't get away from them. Next slide, please. Turning back to adult caregivers in general, we are starting to see surveys indicating that, as we may have guessed, the pandemic has exacerbated many of the pre-existing stressors and challenges of caregivers. So you can see here a survey taken, at the end of March by the Us Against Alzheimer's A-List found that 82% of caregivers say stress is higher, 74% are more concerned about finances, and many are concerned about keeping their loved ones with neurocognitive disorders at home and to keep them safe. Next slide. I also wanted to present some anecdotal information from our Council on Aging Reconnect program case managers who work with older adults who are also caregivers, which is a large proportion of caregiving, as I'd mentioned, as well as my own clinical experience working with our program participants. There's some themes to the concerns that our participants are expressing. First and foremost, there's a theme about less access to, or in many cases, the complete loss of respite care, like adult daycares. Many are reporting that they have no respite now, are with their care recipients 24/7, and are feeling exhausted with caring for them without any relief in sight. Next. Many report that it's been challenging to coordinate or access care for their care recipients and or for themselves due to disruptions in healthcare delivery in these past few months. Next. Transportation services have also been limited or paused in the county due to the pandemic, and many of our participants relied on these services, which has been very challenging. Next. Social isolation has been particularly difficult for older adult caregivers in terms of being able to access their own social support. And also for caregivers whose loved ones are in nursing facilities, this has been a very stressful and trying time as they've been unable to visit them. Next slide. I'd like to end by reviewing some interventions that would be helpful for caregivers and older adults, as noted by the caregivers themselves in the NAC-AARP survey that I've been referencing, but also correspond to the concerns expressed by our older adult caregivers that I just reviewed. So first and foremost, their intervention that they ask for is respite care, including transportation services for care recipients and caregivers alike to take advantage of this care. Next. The second most helpful intervention per caregivers is related to being able to keep their care recipient safe at home with services like house cleaning, meals, home health aides, and physical therapy. Next. In terms of educational needs, the most important information is related to manage their care recipients' health needs, how to manage their own caregiver stress, navigating forms, paperwork, and eligibility for services. Next, please. The majority of caregivers also feel that the following public policy interventions would be helpful, like an income tax credit, a program to pay caregivers to provide care or paid leave. We can all advocate for these policies with our state and federal representatives. Next. I also wanted to mention a few action items that we can all do or advocate for right now. There's currently a $54 billion shortfall resulting from lost revenue and increased expenses caused by the COVID pandemic in California. There is a budget that has been passed by the legislature that's being considered by Governor Newsom over the next month which currently preserves the funding that our caregivers and older adults in Orange County rely upon, but it also depends heavily on federal aid, or counts on it rather. And if you go to the Alzheimer's Orange County website, you can find the contact information for your state senator and assembly member to advocate for our caregivers. And there's also a link to send an email to the governor. Additionally, as Allison mentioned at the top of our session, the House of Representatives has passed the HEROES Act in May, which would provide more funding to states, which we could desperately use to maintain these essential services. However, the Senate Majority Leader and White House have unfortunately not expressed interest in further supporting another pandemic relief bill. So we should all call or email our federal representatives and senators to continue to advocate for our older adults and caregivers. Next, please. And on an organizational or workplace level, I wanted to mention that we can advocate for family leave policies that help our colleagues who are also caregivers. And for those of us in healthcare, we can bring greater awareness that caregiving confers health risks. And at the very minimum, ask if our patients are caregivers so that we can counsel them appropriately and monitor their health risks in the same way that we are starting to screen for adverse childhood experiences. Next, please. And I wanted to mention on a personal and community level, we can all reach out to the caregivers in our lives to offer support. We can engage in pro-social behaviors like wearing masks when social distancing is not possible to protect our vulnerable populations, and comply with social distancing by physically distancing without socially isolating. We can also, if we ourselves are caregivers, make sure that we are attending to our own physical and mental health. Next slide. This is a brief list of resources in Orange County for older adults and caregivers. You'll see that many organizations have shifted to providing virtual support groups and virtual services. And I just wanted to note that thus far in surveys, unfortunately, only about half of caregivers report using software or other technological tools to help them. So I think that that highlights the need and opportunity that we have to think creatively about providing access to these resources and services during these pandemic times. Next slide. And these are my references, and that brings my presentation to a close. And so with that, I thank you so much for your kind attention. And I will turn the mic now to Dr. Ramos.
All right, can you hear me now?
Yes, thank you, Dr. Ramos.
All right, yes, so technology, huh? We think we know Zoom and it escapes us. So thank you very much for the opportunity to present with my esteemed colleagues. And I am going to be presenting on how perimental mental health has impacted us in the times of COVID. I know we've heard some presentations from Dr. Chu, and we've now heard some more information, more importantly, on the caregiver aspect of things. And it's really important that we focus on the caregiver. Oftentimes we find that that's the second person that is impacted and affected. So if I can get the next slide. So I'd like to start out with a case, and we can, I think, all associate knowing somebody, if maybe it's one of our patients, one of our relatives, but this patient is a 31-year-old Hispanic female. She's pregnant with her second child. She is married, is 34 weeks pregnant, and she has a history of postpartum depression. She has a 4-year-old son. And her normal job is a manager at a hotel, but now with the shelter in place, she is starting to feel stressed. She probably is having telephone prenatal care, phone encounters, because as you know, the visits during pregnancy have been limited to try and decrease the exposure to any asymptomatic COVID carriers. So what is it that we can be expecting? Well, not only is her risk for depression higher because of the fact that she had postpartum depression, but more importantly, now with the sheltering in place, we've heard that it increases just in and of itself the risk for depression. We know that stress can become toxic, and living in an environment where we had to be sheltered in place, where our homes now became the daycare, it became the school, became our place of work, and maybe in her case, she was furloughed, the stress is even greater. And we've heard the increased risk for domestic violence and for child abuse. So really, this is an opportunity for us to stop and think, what else is happening? And when encounters are being done over the phone, to really maybe spend an extra 5 or 6 minutes asking what are the social determinants of health that perhaps are impacting her health even more. We know that chronic stress after 6 weeks can start to manifest symptoms of depression. So our shelter in place was over 3 months. You know, we were going on 12 weeks or past 12 weeks. So after 6 weeks, you have an increase in symptoms. Now you can start to imagine, and we've heard the data and the statistics, why so many patients are exhibiting more signs of depression. Can we go to the next slide, please? So I wanted to highlight the fact that the impact of COVID has been not only on those who have a history of perinatal mental health, perinatal depression, or just even depression in general, but it disproportionately impacts people of color, Hispanic, African Americans, and oftentimes we stop to think, well, why is it that it's Hispanic, African Americans? Well, if we stop to think about the fact that many of the employees for essential workers are of Hispanic or African American origin, they're probably the ones that are being kept working and being put in the front line to continue providing the care of their services. Or as in the case with our patient, she works at a hotel where at the peak of the shelter in place, 90% of all hotel industry was shut down. So if there is no income coming in, there's even more stress. The impact of COVID didn't cause the diseases more so in minority populations, but I think it enlightened us to the underlying high risks that are already present, that are already occurring, meaning that maybe the health insurance, maybe there was limited prenatal care or limited preconception care. So if you had a patient that had hypertension, diabetes, some other medical complication in the time of COVID, it really may not be a way to provide the best care. And the other thing that we have to keep in mind is, yes, telehealth has been skyrocketed since the impact of COVID has come into place, but that doesn't necessarily mean that everyone has the same access. We know that, yes, there are some telephone encounters that can be done, but the other thing to remember is that not everyone has access to the internet. And this has really come to light, not only with our patients, but more importantly with some of our children when they're trying to access schools remotely. So again, just keeping in mind that women who are at risk with depression, anxiety, are at increased risk, during this time of COVID because of everything that is happening. With 1 in 5 women in Orange County and in the country being impacted with perinatal depression, with depression in general, this is something that is very real to many. Can I have the next slide, please? So I mentioned in terms of data, 1 in 5 women in California suffer from depression or anxiety and while they're pregnant or giving birth. And I want to emphasize giving birth because right now in the hospital, depending upon what facility the woman is delivering in, the partner may not be able to come into the hospital, may not be able, usually maybe there's 3-4 people present at delivery, and now maybe there's only 1. So somebody that has a history of anxiety, she has to now labor alone. That anxiety can really increase more and trigger a lot of other mental health issues that are not going to just impact her, but are going to impact the baby, impact the rest of the family. So stressors that increase the risk for depression, we've heard, are poverty, adverse childhood events, and COVID. And again, the whole family is impacted. And you can see on the slide the symptoms of depression in California, just how it really breaks down in terms of prenatal, postpartum depression, and either both prenatal, postpartum with 1 in 5 women. So can I have the next slide, please? So again, some of the risk factors, we talked about it. Low socioeconomic status, I'll just highlight a couple of them. unplanned or unwanted pregnancies, current stressful life events like COVID, and some adolescent parenthood. And we've already talked a lot about the financial support. And right now, lack of social support, right? There was a time when we really were shelter in place, and we've heard that there wasn't the availability for those grandparents to come visit and to come help because of the increased risk for the grandparents' health. So really, all of the support that the mom would normally have is really compounded. If you have a family that lives in a very small apartment that maybe has 4 or 5 people living in a 1-bedroom apartment, you can really start to imagine how the stress increased even more during the shelter in place. And all of that has been cumulative, and it's now starting to be manifested. Can we have the next slide, please? So racial and ethnic disparities, we talked about this. Unfortunately, there's a disproportionate higher number of symptoms of depression and anxiety among women of color, and you can see the breakdown here with a higher proportion for in the Black population and the Hispanic population. So, and you can see also the data for the Asian and the white. So nobody is immune. Unfortunately, you know, we all have that risk. There is no discrimination in terms of who can be impacted and affected by depression. It's a disease of everyone, and none of us can really escape it if we have all of those risk factors that are working against us and put us at increased risk. We have the next slide. So again, I mentioned that mental illness can impact the infant, and you can see here how anxiety disorder and major depression can impact the obstetric outcome as well as the neonatal impact on as well. So big important takeaway I would say is that the mom's health really impacts the baby's health. You can see that developmental milestones can be impacted. You have increase in the baby. Bonding can be more difficult in a mom who has anxiety or depression. And there are some increased risk for fetal growth, decreased fetal growth in women who have major depression. So really important to address and screen for depression, anxiety for moms right now when they're pregnant and postpartum. So next slide, please. So here in Orange County, the healthcare agency has come out with a fantastic algorithm on how we can actually manage somebody that we screen, and if they happen to be positive for depression or anxiety. And this is found, I have the resources at the end, but you can find this on the OC Health website, and they have a beautiful algorithm. So many times we're afraid to ask about depression, anxiety, because we don't know what to do. Well, this is your playbook to know exactly what you can do and where you can get the resources. Can I get the next slide, please? And this is a screenshot of the Edinburgh screening for depression, and know that there's also a PHQ-9. Really important to take into consideration is that the Edinburgh screening for depression actually takes into account pregnancy, because many times you'll hear the question, have you been tired? Have you been, don't have the energy to do your usual activities? Well, for a new mom, a postpartum mom, the answer is going to be yes, whether you're depressed or not. But the way that the Edinburgh is framed, it actually takes into consideration the postpartum mom. So it helps more so with the screening. So you may be asking yourself, when we heard about the caregivers, we heard about the extended circles, well, what are some considerations that we can maybe do to care for people who are loved ones, our patients, and screen for depression? Well, perhaps you can do a remote screening. You can ask the questions over the phone if the mom doesn't have the transportation, or if you're doing a visit, and you can assess what help is needed. And again, the HCA, the Orange County Healthcare Agency algorithm has the information that you can use to determine what the next steps will be after that. Can I have the next slide? So back to our patient, you know, we talked about the fact that she's at increased risk for depression, that she also the impact on her infant is going to be higher if she is depressed again, because that stress really can trigger the depression in somebody who has a history of depression. And it's great that she is married because the partner can hopefully be supporting her. But many times, you know, we've heard about increased risk for intimate partner violence. We don't know what the situation is there. So it's really important to ask the question and to do that screening. Now with some of the telehealth visits where you actually can use video, you can actually see what the home looks like of the patient. So if there is if there's a lot of disorder, chaos in the background, you can maybe start to ask, maybe there's something else that's happening, and do some further questioning. But we all have the opportunity to help our patients and our friends, our loved ones, to get through this, especially now in light of COVID that has increased the stress so much more for everyone. And in particular, we've got 2 extra patients with the mom and the baby. Can I have the next slide, please? So treatment, many times we think that treatment is just medication. Well, treatment is actually more than medication. And this is really important to share with patients, because depending upon how the severity of their depression, it could be psychotherapy, it could be just family support. For those rare cases, there may need hospitalization, but medication may be something, as well as some self-help could be another thing. So really important. Many times patients may be borderline depressed. They may think, oh, I have to be on medication. It's that negative stigma. But we need to make them aware, look, depending upon where you are, it may determine the type of treatment that you may need. And sometimes it's a combination of everything, or maybe it's just one thing that's just going to help them get through that transition. So we need to take into consideration the cultural impact as well, that many times women, especially of certain ethnicities, see having a mental issue as something taboo that you don't talk about. And I can tell you in the Hispanic population, that's something that oftentimes happens. We say, we don't say that you're depressed, we say that we're nervous. We're nervous and we're just not feeling well. So we need to take that into consideration, be considerate how we're framing mental health issues. Next slide, please. And support, we've heard what we can do for the support providers, but what you can do, again, this goes back to the portion of that slide on treatment, is that really we can offer support and encouragement, help the mom feel that she's not alone. Sometimes you just need time to talk, encourage going out, going walking, ensure her that there is help. And if you see it, maybe you can help connect them to the right medical care, whether it's telemedicine or in person. And that this too shall pass, you know, like everything else, and that you're there to support her. But as we heard before, we need to help also take care of that healthcare provider, that support person. And if I can have the next slide. So in terms of knowing what we need to be doing for COVID, what should we be doing in terms of behaviors to ensure our safety and as we get back into society? As we start to open up. Well, my son actually developed this game. It's called COVIDblast.com. He saw me, he's 13 years old, and he saw me talking about COVID, and he came up with this game that takes into consideration the coronavirus.gov recommendations, and it's in a form of a game. So the white blood cell destroys the COVID. Check it out. And the next slide, please. And finally, I will leave you with a plug. We are actually going to be debuting a toolkit focusing on perinatal mental health. And this is done in conjunction with the Orange County Medical Association, First Five, the healthcare agency, and many other partners throughout the year that we've come together to try and address something specific for perinatal mental health. And we're going to have the presentation, the debut on June 9th, and Dr. Chow is actually going to be one of our speakers. So what I would invite you to participate and listen in, and that toolkit will be available on the Orange County Medical Association website and the First Five website. And last slide. And here is a list of resources, and I understand that all of these are going to be available afterwards. So thank you for the opportunity. Can I have the last one? Thank you for the opportunity to present to you and to share, and really to emphasize the fact that we all need to help each other stay safe and healthy, but more in particular our pregnant moms, postpartum moms, because it's such a susceptible time for depression and anxiety. Thank you.
Okay, I want to thank all three of you for those excellent presentations. We will now move into some Q&A. And the first thing, I'm actually going to take the prerogative and ask, talking about the increased incidence of both suicide and domestic violence that we're not surprisingly seeing and suspecting there's even more, do you have any advice for those of us in the field for reaching out and identifying and helping those people who are isolated, who are at most risk for these problems?
I guess I can answer that. I think that the most important thing is for a staff to arm yourself with resources and also just come right out and assess. I think in the mental health field, many of us are hesitant to assess people for suicide. Believe it or not, we still have that myth that if you ask, it's going to happen, even among mental health professionals. So when I train student and clinician, I tell them, you just have to do it. You just have to do it. But don't just do it and then leave people hanging. You have to really have a lot of resources in your hands so you can make appropriate linkages, right? And linkages here doesn't mean here's a number to call. You really need to do what the new phase that I've been talking about now is warm connects. You need to warm connect people. Don't just give them a list of phone number just to call on their own. So.
Thank you, Dr. Chow. Dr. Park or Dr. Ramos, do you have anything to add to that?
I can add just to piggyback on what Dr. Chow had said. I think if you're speaking from a clinician standpoint, I guess, in terms of looking at your panel, looking at the folks that you work with and trying to figure out how do I reach out given all of these increased risks that are happening in the pandemic. I think, as Dr. Chow mentioned, asking about suicide. So, you know, when we do suicide screening, there are various different risk factors that we keep in mind, and there are various different elements of a history that we try to assess for each individual. And I think in terms of my presentation, there are many things that I learned about in terms of caregiver risk for mental health as well as physical health that I think should be kept in mind as a risk factor, not just for depression, anxiety, for suicide, and knowing, as Dr. Chow said, that the financial impacts have been shown over time to have a significant impact on suicide. I wasn't aware of that, Dr. Chow, in terms of that there's a clear sort of correlation in terms of percentage unemployment with increased suicide risk. I think that those are the elements of what I think we can use as clinicians or folks who are working with people at risk for mental health illness during this time to gauge sort of our intervention and to have a more full kind of suicide and mental health screening approach. I hope that makes sense.
Thank you. Dr. Ramos, did you have anything to add?
Yeah, I would just say in terms of helping, I would screen everybody. And I would say also, you know, we have the simple tools. The surveys to do so. And, you know, one thing to take into consideration is as Allison shared, this is a covered benefit. And also the Women's Preventive Service Initiative just added anxiety as a recommended covered benefit as well for all women. And so we need to take the opportunity and just screen and help those that need it.
Okay, great. Thank you very much. So I'm going to jump. We've had several of the questions that we're getting. I'm going to direct to Dr. Chow because they have to do with the county directive around masks.
Okay.
And the question's asked in several different ways, but basically it's saying, you know, for those people who wear masks, being around people who don't wear masks is causing stress. Can you give us some more direction and explanation of the county decision on not mandating masks?
Sure. So for those of you who live and work in Orange County this last 3 weeks, you probably have been following the major issue around masks. And it's not just in Orange County, it's all over in the country, and particularly in California. And I believe that the issue around mask covering and order and the role of the health officer has caused an exodus of a number of people who hold this position locally, particularly the health officer. You probably heard people who resign, people who retire early, and people who basically was fired because of this public health order that had been turned into politics. And so in Orange County specifically, when we applied for the variations to reopen the community, our former health officer and I decided that we will put in a requirement for masks for everyone to wear in Orange County. Unfortunately, our local sheriff also publicly said that he won't enforce it. So you see the dynamic between having an order but no way to enforce it, right? So it caused a lot of anger from a group of folks who thought or still believe that this order is impinged upon their individual right. And I have publicly said the science of mask is new, and we know this. Every day, every week, there's new publication talk about masks from a scientific point of view. And we were very clear in the beginning that wearing masks is not about protecting the wearer, but much more about protecting other people, right? Especially individuals who are belong to the vulnerable community. And our order, our formal order said, only when you're not able to keep yourself 6 feet from other folks. Because the 6 feet distancing is very important. And so you probably, for those of you who live and work in Orange County, you probably heard what has happened to our former health officer as is related to protests. People were picketing in front of her house, death threats in social media, and clearly in front of the board supervisor meetings. And then her addresses has been shared widely in the social media. That prompted her to resign or separate from the county. The day before she resigned from the county, and so on top of that, there has been inconsistency from WHO to CDC to the State Department of Public Health as is related to face covering guidance, right? So CDC and WHO only recently strongly recommend, I think CDC only recently strongly recommend face masks and doesn't say that it is a requirement. That's the difference. And WHO is wobbling back and forth about it. And WHO previously, as of 3 weeks ago, state that mask has no use. Only recently did they change that, okay? And CDPH, as we reopen the business into the community, different sector into the community, every single guidance for business to do due diligence before they reopen. The piece on face covering is not a requirement, but rather a recommendation. So the wording here is not a shall, but a should, right? So that's number one. Number two, there was no guidance on how do we, when we apply to reopen the business, there's a piece on the application we need to speak to, and that is how do you contain and what would you modify if you notice that your situation in your local county is worsening. Meaning if the number of deaths and the number of positive rate increases, and then your personal protective equipment dwindle down, then what do you do? And at that point, there was no guidance from the state on, well, what is the marker? What core measure do we follow in order for us to say, aha, we are now getting into a dangerous situation that we need to remediate, and what is the plan of remediation? So a day or two before Dr. Nicole quit, because of all of this unfortunate, unseen public outrage of a smaller group, but unfortunately they are the loudest group, right? And so, the state issued what they call a monitoring guideline. So there are several factors that the state said, we will monitor you. If you hit this if you hit this mark, then you need to submit to us a plan on how you're going to remediate. And so my strategy was, if our guidelines for face covering, first of all, is not consistent with the state and the CDC, already put us there, meaning if we need to remediate, we can't say we are now going to enforce masks, because that doesn't make sense. Your order said everybody must, right? Then the next option that we need to do would be start closing back down businesses. And you and I know that would be a day in a hot seat if we start reclosing all the businesses. So my statistic epidemiologist team look at our data in Orange County. Now, I know Allison talked about the number of people who get infected increasing, but that's expected. As you reopen the business and people are back into the community, you will see more infection, right? But it means that you really have to test everybody and look at exactly the rate of how many people who are infected compared to all the people in the population. And so that is the established rate, and the state has a rate and said, if you cross that threshold, then you need to remediate. The other monitoring criteria that the state has is the percentage of ICU bed available, as well as the percentage of ventilator available. And from all of those measures, we are actually doing very well in Orange County, right? And so if you base on our statistic and you base on, should we ever get there where I need to come up with a remedial plan, I have nothing except for, I'm just gonna start closing down businesses. And knowing that nobody enforcing the mask, so I scale it back from a shall to a should, because my strategy is, should we ever get to the point where I need to come up with a plan, then my plan would be, okay, now we're gonna really make everybody wear a mask, okay? And with that, collectively, if the community decide that our first step of remediation plan is everybody wear a mask, then the sheriff cannot say that he won't enforce it. Does that make sense?
Yes.
So he's gonna be forced to enforce it, because if he doesn't enforce it, then we're gonna have to start closing down business. And he would have to respond to the business community on why he allowing us to get to the point where we are closing down businesses.
Thank you, Dr. Chow.
Okay.
We just have time for one more question, and this is aimed toward Dr. Park. Can you recommend strategies to have conversations with older adults around the risk of depression and suicide?
Sure. I think that that's a great question. And I think that it is, so the question is, it sort of depends. But I think there are certain principles that hold true regardless of the setting that we're talking about. I just wanted to say that in terms of having conversations with the older adults in our lives, for example, on a personal basis, I think the same principles apply whether you're working in your community or other folks within your professional capacity, or if you're doing it in your personal life. The thing to keep in mind is that having conversations about depression or their suicide risk, or the risk of depression in the midst of the pandemic, is aimed towards figuring out how we can best support our seniors, obviously. And the number one protective factor for seniors, for older adults, is social support. So I would just say from the get-go, by starting to have the conversation, by reaching out and indicating that you care and indicating that this is something that you're concerned about for an individual, that is a major protective factor in terms of depression for that person. Social support, we know, is the most important thing. That being said, I wanted to go over some principles as developed actually by folks at my agency, Carolina, who is our director, and Sarah Kim, who's our clinician, about talking about suicide in particular, but I think this applies to anything around mental health. So some principles I would recommend are being direct. As Dr. Chow said, there is a lot of stigma around talking about suicide in particular, or even talking about depression, and that occurs, that's internalized even for those of us who are clinicians. So it's really important to be direct and be open and to talk about what it is that you're concerned about, and to ask specifically, if you're concerned about suicide, have you been thinking about suicide? And not to fear that by somehow, as Dr. Chow mentioned, by talking about it, that somehow you're going to plant the seed in their head. If they're thinking about suicide, they're thinking about suicide. You asking about it doesn't make them more likely to think about it. Being willing to listen, being non-judgmental, and reassuring them that help is available. So obviously when we talk to older adults in our lives or in a professional capacity, it's not as if we're going to ask like, hey, are you depressed? And if they say yes, you're just going to leave it at that. Obviously you want to be able to reassure them, hey, you know, if this is an issue for you, we can get help. We can find these resources. We want to try to find intervention so that things feel better. Being honest is obviously very important about what you know and what you don't know, what you can and cannot do. And I think those are some general good principles to talk about depression and suicide risk.
Thank you very much. So for those questions we didn't have an opportunity to get to, please know that we will post the answers on our website. Now I want to thank Dr. Chow, Dr. Ramos, and Dr. Park for their time and for sharing their expertise. That was a lot of information shared today. And we appreciate the wonderful work you are all doing in Orange County to advance the mental health of our community. I'm now going to turn this back over to Allison Sonnenschein, who is going to close out our final session of the Women's Health Project 2020 Summit.
Thank you, Gail, and also to our incredible panelists today for sharing so many helpful insights and constructive advice on what we can do to move forward to address mental health. And as we heard, every population segment has been affected profoundly with regard to their mental health because of the COVID-19 pandemic. And I just wanted to recap at an individual level, it is important that we all engage in self-care and that we check on our neighbors. I think the importance of screening has been very well highlighted here. We've called out ACEs, or adverse childhood experience screenings, maternal mental health screening, as well as a suggestion that we start screening our adult and older patients as to whether they are providing caregiving duties, because that does carry some physical and emotional health risks as well as screening for underlying social determinants of health. We definitely want to increase our county's capacity to provide mental health care moving forward, as we do anticipate a significant increase in demand for services. And to facilitate that, we should continue using and advocate for the ongoing use and reimbursement for telehealth. We have to be mindful that there are still communities who are unable to or uncomfortable using telehealth. They are not familiar with the technology. They may not have access to internet service, but we should nevertheless be working to advance access while we continue to push for reimbursement parity. And something we mentioned last week during the policy session is that we have temporarily authorized reimbursement parity for mental health care and for telehealth specifically. So what that means is providers should feel more comfortable, especially private providers who work in private practice, that they should feel more comfortable using telehealth because at least for the time being of the public health emergency, they will be eligible for equal reimbursement, regardless of whether the care is provided in person or via telehealth. We need to, as Dr. Chow mentioned at the beginning of the session, meaningfully integrate physical, mental health, and substance use treatment. And we also have to increase, as Dr. Park recommended, the supports for mental health, such as respite care and transportation services, paid leave and caregiver pay. Dr. Ramos suggested that we all check out covidblast.com, a new game, a video game app that helps us learn about best practices for handling the coronavirus. And finally, we really must be very intentional in addressing the racial and ethnic disparities that have been highlighted throughout this pandemic. And we are continuing to see these disparities at play in mental health, as was discussed today. So with that, I want to thank everybody. There's a lot we can all be doing, not only to educate ourselves, but actively doing to increase care, to support integration, and to advocate for the resources that will be necessary to address the long-term mental health consequences of the COVID-19 pandemic. Finally, I just want to remind you all to please complete your evaluation. If you are looking for CEUs, be sure to submit the request form. And we encourage you, if you haven't had a chance, to please watch the first, second, and third sessions of the Summit series, all of which are available on the Summit website. Thank you so much for joining us today, and we will follow up as we best can on the questions we were unable to get to today. So look at our website in a few weeks, and we'll post the answers as we can compile them. So thank you so much. Have a wonderful day. Stay